Kimberly Seals Ehlers is an award-winning journalist, 5-time author, international speaker, strategist, and advocate for maternal and infant health, a former senior editor at Essence and writer at Fortune magazine. Kimberly is a leading voice on the racial and sociocultural complexities of birth, breastfeeding, and motherhood. She is a founder of Irth, a new Yelp-like app for Black and Brown parents to address bias and racism in maternity and infant care. Kimberly is also the host of Birthright, a podcast about joy and healing in Black birth that centers positive Black birth stories as a tool in the fight for birth justice and to reverse the narrative of negative statistics that is common in mainstream media coverage of Black maternal health. www.birthrightpodcast.com is where you can find more information. Introducing Miss Kimberly Seals Ehlers.
Hi, everyone. So great to be here and to share space with you. Such powerful information this morning from Keisha and from the other speakers. I feel like I'm traveling all over. This is my second conference this morning, so it's great to be here with the folks representing Georgia. So I'm excited to talk to you about how we can actually center the lived experience as we work to address the disparities that we know exist across the perinatal continuum. And then what are some of the digital tools and platforms that may be able to assist us in this journey? Let's start the slides, please. Next slide. All right, so as was mentioned, I come to this work as a journalist. So I like people to remember that I bring that lens to my work and really thinking through how I've used my experiences as a journalist, as a storyteller, as a person who's very interested in narratives and what those kind of learnings can bring to the work that we're doing today. Next slide, please. As was mentioned, I am run a nonprofit where we host Birthright, the podcast, and the Irth app, which we'll talk about today. Next slide, please. So what do we know is going on? We know that despite earnest efforts and research that Black women are still disproportionately dying during pregnancy and after childbirth within the current medical system. In fact, repeatedly, Black and Latinx women report that they feel that their race, ethnicity, sexual orientation, or even their language skills are impacting the quality of service that they receive. And as a result, right? As a result, we know that Black women are actually 243% more likely to die during pregnancy and childbirth. I live in New York City, and in New York City, the Black maternal mortality rate is 12 times that of white women. And so when we look at all these issues, when we look at the scope of what has been happening, what has been tried, we really have to really acknowledge the impact of racism and bias in our care. Next slide, please. We know we've seen the media start to pay overdue attention to this issue in terms of looking at this issue. Next slide, please. And just recently, if you saw the New York Times reporting on the latest data that showed like during the pandemic, maternal mortality increased with Black women experiencing the largest increase, representing 1/3 of the deaths that have happened in the pandemic, even though we are only 13% of the population. And so when we understand that we have a broken system and any kind of stressor, including a pandemic, is only going to exacerbate those cracks, it's only going to show us where the brokenness was and expose it and lay it bare. This is exactly what has happened. And so we know that across the board, when we look at the ways that the system works, when we look at the ways that the system is failing, Black women are disproportionately bearing that burden. Next slide, please. And when we think about this issue, for years, there was this kind of problematizing of Black women. They don't go to prenatal care. This is a socioeconomic issue, and all these other factors, which have been actually disproven by research. We know that income and education are not protective factors for Black women in their birth outcomes. In fact, research has shown that a college-educated Black woman is actually at a greater risk of low birth weight baby, preterm birth, and dying than a white woman who graduated high school, right? And then we look at what happened to Serena Williams. Here we think of one of the greatest athletes of all time, certainly a celebrity, someone that we think would get more attention. And yet she literally had to fight for her life. And I like to remind people that she was there with her millionaire, he may be a billionaire, white husband, and still could not be heard. Right. And so there's something we have to acknowledge about what happens when people see Black skin that creates something that causes them to act differently. The issue of implicit racism and bias, implicit bias and structural racism has been well documented in many academic journals, many studies, you name one, they've written about it. So we know this is a thing. We know this is a thing. It does not need to be studied. One landmark study showed providers were giving different treatment options to hypothetical white patients than they did to hypothetical Black patients presenting with the same symptoms, right? So there's something about the Blackness that's impacting the care. It's not the knowledge of the provider. They're able to provide the care. A disparity means that it's happening for some, but not happening for all, right? Next slide, please. And so even we looked at, again, the New York Times this week, doctors, two studies showed that doctors were more likely to put derogatory comments in the medical records of Black patients than they were for white patients. So do you see the pattern here? Do you see the pattern here? And so when we ask the question about why Black women continue to have these lower than optimal birth outcomes and continue disproportionately die, we really have to have the conversation about the things that the studies are constantly showing us, right? Next slide, please. Yes, and I love this comment from this doctor in this New York Times article about the studies, which really talked about listening, thank you, listening to patients, right? How can providers learn to listen? And this is what this doctor commented was something that she was told by her own father, who was a physician. So is there something in the listening, right? We've talked about the care and the clinical approach, but maybe there's something so simple in the listening that hasn't happened. And then we have to ask why the listening hasn't happened. Next slide, please. Thanks. And now we even know that some algorithms, technology being stacked against Black patients, right? Where can we turn? Where can we turn? Next slide, please. And so we cannot decouple what's happening with Black birth outcomes, Black breastfeeding rates, Black infant mortality rates. And if we take a historical perspective, knowing that Black women always successfully birthed children, our children had economic value, and we birthed and breastfed not only our own children, but the children of our slave owners, often even to our own children's detriment. But yet now Black women are breastfeeding the least, dying the most, and their babies are dying the most, right? We can't ignore the thread there. And so we're left with the conclusion, as Dr. Joy Perry says, it's racism, not race. There is nothing about my Black skin or my melanation that makes me more likely to die during pregnancy or childbirth, but there could be something about the care that I receive. And I love this definition from Dr. Kamara Jones, who really talks about racism as the system of structuring opportunity and assigning value, right? Based on the social interpretation of how one looks. Because right now, when we think of racism, sometimes we think of epithets and tiki torches and people using slurs. No, that's not what we're talking about, right? It's an idea of assigning value. Whose comments about their body are worth listening to? Whose babies are worth giving extra attention to? It's this assigning of value that's really at the crux of what we're talking about. Next slide, please. We can't ignore the historical trauma. I saw this was already mentioned. Next slide, please. Around the medical field and the ways that Black people have been used. This trauma extends through breastfeeding. As I mentioned, where Black women were disproportionately stopped from breastfeeding their own children and forced to feed the children of their oppressors, right? A disruption of the mothering experience and assigning a value of who deserved the milk, right? Next slide, please. We see stereotypes about Black women. If you Google Black women in Google search, my God, you'll get all sorts of things around welfare queens. We can go back to the Moynihan report. Is deeply troubling to me that the media has portrayed Black women as desirable and capable of taking care of other people's children, but somehow incapable of taking care of their own. Next slide, please. And so when we think about this history, all of it, all the pieces, all the things, we have to understand there is an earned distrust of the medical system, at times of providers, at times regardless of color. And so what are we doing to build trust, right? I like this quote from Dr. Neil Shaw. It's not for people to expect communities of color to be more trusting. The system has to become more trustworthy, right? We've seen this lack of trust play out during the pandemic with dire consequences. Next slide, please. So what have we been trying? Well, there's been evidence-based maternity care, which has been important, very critical, but often I'm asking evidence-based on whom? The fact of the matter is the majority of the evidence base that's been used to guide maternity care had not included Black and brown women, other people of color. And so we've taken a piece of evidence that wasn't based on a large group of people and applied it to everyone. And perhaps we can look at that as why our maternity outcomes have not improved for anyone in this country, for anyone. The anti-bias training is very critical, important, great start, but there's been zero accountability, no transparency. Unfortunately, it's become a tick the box exercise, and nobody ever checks back in to see whether that training actually improved the lived experience for the folks it's supposed to be working for. Lastly, maternal mortality review boards, very critical. I know Georgia has one, but this idea of death being the analysis point for Black women is deeply troubling to me, right? If we die or nearly die, then you'll examine our care. When there's a whole spectrum of trauma that causes harm, that impacts our postpartum journey and often leads to postpartum depression, that is happening as well. And so instead of waiting for us to die, I say, let's learn from the living. Let's learn from the living. And when we do that, we need a new framework that says, whatever the question, the answer is in the community, right? How are we getting answers from the community? Not saying that the community is a place that we go to fix and change, but the community may have solutions to how we can improve care. Next slide, please. I often say the experience of being interpreted is different from the experience of being understood, because many times when people talk, they invite me in to work with them, they're like, oh, I read this study. Oh, I read this study about Black people or Latin people or queer people. And, when you're moving from a study knowledge, that's moving from an interpretation. What I'm talking about is developing an understanding of the lived experience of Black and brown folks. Next slide, please. And so we created Irth, which is like the word birth, but we dropped the B for bias. So it's IRTH, really as a tool to, one, provide our community with ratings and reviews and recommendations from other people like them, but to turn those reviews into data that can give us the understanding of what the lived experience is like, and not just wait for us to die. Next slide, please. And so Irth is the first of its kind nonprofit platform for Black and brown women and birthing people to find and leave reviews of their OBGYNs, birthing hospitals, and pediatricians, right? You go into the app, you can search reviews, you can leave reviews. We currently have reviews from 48 states plus Hawaii, and we're excited about the growth that we're having. Next slide, please. And then on the back end, we can, I think you got to click it for the, it's a video animation. Okay, so on the back end, sorry, I was trying to show you some of the screens. On the back end, we turn those qualitative reviews into quantitative data to work directly with hospitals, payers, and providers so they can learn from our robust database of Black patient experience to better inform their maternity care. Next slide, please. And so we challenge this idea that all people are having the same experience at the same place. That was certainly not my birth experience. I did all the research, all the things, read all the lists, and still left the hospital feeling disrespected and traumatized. And so we want to understand that that's not happening. And how do Black birthing people know how someone like them was treated at a particular institution? At the same time, we're here to drive transparency and accountability. The fact is, hospitals have been knowing what they've been doing to Black birthing people and women for years. It's out there. It's been hidden in databases. Now it's becoming a little bit more transparent, but it has not been transparent information. And so how do we drive transparency and accountability with a new message that says you are ultimately accountable to the communities that you serve? You're accountable to the communities that you serve. And so how do we build this in by using technology as a tool to leverage that movement and that momentum? Next slide, please. And so one of the things that I think Irth does really well is we really seek to decode bias. My observation from many years of consulting and working with hospitals is that providers take the training, they think they're doing great, but what happens? The patient is having an exact opposite experience, and there's a huge disconnect. So what we try to do is really ask specific questions to decode what bias, what disrespect really feels like to Black women and birthing people. Right? And so we ask, what happened to you? Were your pain levels dismissed? Was your physical privacy violated? Were your requests for help ignored or refused? What happened? Because we can't keep saying, I don't know what I'm doing, I don't know what I'm doing, right? We have to be able to show. So we can detect patterns and trends of negative practice behaviors, also positive ones. Right now, the #1 negative experience being reported in Irth is my requests for help were refused or ignored. #2 is my pain levels were dismissed. #3 is that I was scolded, yelled at, or threatened. #4 is physical privacy violated. And #5, I experienced rude comments based on stereotypes, right? And so this is what's happening. Let's put some names on it. Let's get the details. As the kids say, let's get the receipts so we can start showing what this disrespect looks like, what it feels like, how often it's happening, right? This is how we try to move this conversation forward. And we want to be an early warning detection system. If a hospital has a high recurrence of dismissiveness of pain levels, when we know that every Black maternal death story, somebody's pain levels were dismissed, or even in the near-death experiences, how do we flag that? How do we become this early warning detection system so we can learn from the living and not wait for us to die to decide to analyze our care? Next slide, please. And so we want to be this bridge. On the front end, we give our community crowdsourced peer reviews from a trusted independent resource. We want to leverage technology to address some of these power imbalances so we can say we have consumer power. We are not the victims in this Black maternal mortality crisis. We have consumer power, and we're going to wield that in this fight to get the health system to be fair and equitable and just. On the back end, we turn these qualitative experiences into robust data. We work directly with hospitals to help them learn from the living and to put that into hospital practices. Whatever you're doing with QI, patient safety, I ask hospitals every day, what does patient safety mean to a Black birthing person? To this point, no one can really give me a good answer. Next slide, please. So in our reviews, people really like to share information. We see sometimes when people are talking about how the makeup of the staff, right? What the staff look like made them feel safe or unsafe. And then we see things like this, not listening to my pain levels. Again, a red flag, using Irth as an early warning detection system. How do we do that? Next slide, please. Here's another review. I just want to show you guys a few. I like this one over here to my right, because this mama ended up in the NICU, right? But really left a great review about the NICU staff and the team and how they cared for her, because there really is a distinction between what happened and how it happened. And that's what I think we need to understand, because we've been counting the clinical outcomes, whether there was a C-section, whether there was this and whether there was that. But how it happens is what causes the grief, the trauma, the pain that carries with birthing people and women for years to come. And so people can make that distinction. Okay, I ended up having a C-section. My baby's in the NICU, but I was listened to. I felt cared for. My pain levels were addressed. That's a whole nother experience. Next slide, please. I'll skip this one for the sake of time, just for showing you some more reviews. Great. And so we cannot continue to separate what's happening during birth. When Keisha was presenting and asking about some things that may contribute to postpartum depression, birth trauma, your birthing experience can contribute to your postpartum depression. And so we must see the continuum of looking at all the things that people are going through and not isolating these moments in motherhood as if they're separate. Because so many times what's happening during pregnancy and childbirth not only shapes the breastfeeding journey, right, but also shapes that postpartum experience. How you birth matters. And if we can help more Black women and birthing people have respectful, equitable, dignified births, we could make a real impact on postpartum depression, right? At least one thing that we can try to address. Next slide, please. And so we want to always think of having a robust community feedback mechanism for all the providers who may be listening. What are you doing to get continuous, robust feedback from the community? This is what we're doing right now in our hospital pilots. We have one in Detroit. We have one coming on in Philadelphia and Los Angeles, where hospitals are saying, you're right, we don't have robust Black patient experience data to inform our maternity care, and we want to listen to the community. What a powerful way. And once we do that, we have this database that we want to use to inform education, a curriculum, and ultimately a hospital accreditation, all rooted in being accountable to your community and listening to that lived experience. Next slide, please. And so ultimately, we can't change what we're not willing to see. We can do all the talking, but if we don't have a way that we're not measuring and seeing and counting some of the harms that we know are being caused, we are not going to get there. And so with Irth and our back-end work with hospital pilots, working with providers, we're able to offer this robust community feedback, this analysis of our reviews, this consulting service that allows us to help you develop the actionable strategies to address it. And then we go back in again and listen to the community one more time to see as a test of change to see if it's working. Next slide, please. And so my vision for Irth is that we become the good housekeeping seal of approval for Black women and birthing people, right? We become that beacon of light, our safety sign for where we can go to receive respectful and equitable care, and that ultimately my community has vouched for you. People who look like me have said they approve of you, right? They have received good care here, and that matters to me. Our work also includes expanding our hospital pilots, publishing a list on a state level and city level, identifying leaders, what's going well when we see hospitals that are consistently getting 5-star reviews, what's going on there and how can others learn from that? And how do we redefine what is a 5-star experience for Black women and birthing people? Too many Irth reviews, when we ask what's the best thing that happened to you, people say my baby is alive and I'm alive. That is not the best thing that should happen to Black women and birthing people in their birth experiences. They deserve joy and they deserve to thrive. Next slide, please. And so ultimately what we need is a coliberation model, one that is not about how do we save and help and fix and repair Black women, but one that understands that the energy we need to bring to this work is because our futures are inextricably linked, and that you're not free if I'm not free, and I'm not going to be free if you're not free, and that no mother will be free until all mothers are free. Thank you so much for this time to spend with you today. I'm so excited and grateful to PSI for the opportunity to share. Happy to take your questions in the Q&A. Let's see what we have. I think the third was for me, for a midwife and lactation consultant listed in the app. No. So, however, when you go through the birthing track, you are asked about the doctors. nurses and lactation consultants. So we collect a lot of breastfeeding data because for me, as everyone knows, I'm a big breastfeeding advocate. Shout out to Black Breastfeeding Week, August 25th to 31st. We want to see what are these in-hospital experiences happening and how could that be impacting their breastfeeding journey going forward. However, if it is a hospital-based midwife, you can leave a review. And just to clarify, Irth accepts reviews from the birthing person, fathers, as well as partners, doulas. We accept reviews from doulas. We actually have a special icon for doula reviews, and we accept reviews from hospital-based midwives who also may need a place to share. So great question. Yeah, so we are concentrated in kind of major cities. I would love to reach out if you're interested in helping us get more reviews in the Savannah area. We would love to hear from you. We work very closely with community-based organizations, really helping to spread the word. We're happy to get you promotional materials, see what else can happen, but would be happy to support in that. Absolutely. All reviews, can nurses report abuse of providers anonymously? Absolutely. All reviews are anonymous. Our reviews, you are verified as a person through our technology, but all of the reviews are anonymized. So we do go to great lengths to protect. Also, this reminds me, we also don't show reviews unless we have at least 3, in some areas more than that, as a safety feature so that nobody is alone in Irth. Because we know that sometimes even without a name, the circumstances may help, may in some way identify you. So we make sure that nobody's review is out there on its own. But yes, we appreciate that. And we do see nurses coming in to share. When you're asking adding the midwives, like I said, if a midwife works at a hospital, then they will come up, and because they are attached to a hospital. If you're talking about midwives who work in childbirth centers, we don't allow reviews of childbirth centers at this time. I think you can probably technically do it, but it's not something we focus on. We do view childbirth centers as part of the solution. And so, and although they are not perfect, we are focused right now on hospital systems where we know the death rates are unacceptable. Yes, the data is shared with the hospital. The hospitals in our pilots programs are absolutely receiving the data. They participate in a review collection process with them. The hospital has to assist in reviewing itself. And then after we go through that initial collection period, we present that data to the hospital. The hospital has already developed a working group that includes hospital leadership. We co-create solution based on what we've learned, develop strategies, set some time for those strategies to set in, and then we start reviewing again, right? We want to be constantly getting feedback from the community and Irth as a ongoing community mechanism. Oh, great. We would love that. I can put a link in the chat for you all to have access to our social media toolkit. We would love for everyone just to share about Irth on their platforms. I'd be so grateful for anything you can do. Put in your newsletters, your text messages, and feel free to reach out to my team and myself directly. And we're happy to help more. Yeah, I don't know what kind of provider you are, Michelle. We're currently working with some pediatricians here in New York City who are starting to display signs that say, how was your birth? Leave a review on the Irth app. And so we're really engaging pediatricians who often apparently hear a lot of these stories and don't have a tool to direct people to. And so if any pediatricians out there are interested in helping support our work and allowing people to leave their birthing reviews, that would be awesome. Our data is not being shared with the CDC. We are not there yet, but would love to make that happen. And certainly as we get bigger, we would love to do this. Open to conversation about Massachusetts. We're here for all states. We definitely have a product map to expand Irth into other areas of women's health. Thank you for that, Middle Eastern. Be happy to take that back to the team. Hi, Dr. Jackson. Wow, it's such an honor to just see Dr. Jackson here. Wonderful. Thank you so much. Yeah, we see that. We see colorism addressed in reviews. Also, we also see many biracial couples, many times White women share reviews about the treatment of their Black husbands and vice versa. Black husbands leaving reviews for their, because they feel like something about their race impacted their care or their partner's race. And so we certainly see elements of that in our comments. We see elements around colorism in the comments. So all of that does get addressed. And then in our back-end analysis, we're able to tease that out through our sentiment analysis, through our pattern work. So these are all great things that we're working on. But more reviews in help us get more data and help us learn. And so any, suggestions or support around helping us get completed reviews. We have a doula ambassador program that we're launching in New York City, where we are really working specifically with birth workers and asking them to help their clients complete reviews. It is a structured review process, takes about 10 to 12 minutes for the birthing review. And so it's not Yelp-like in that you can just go in there and leave a free form comment. There are very specific questions that are asked that help us get the best data on the back end. Happy to entertain questions. Please feel free to email me and Jennifer anytime. Really grateful for this robust conversation and an opportunity to share. So much work to do, and I'm excited to be in it with you all. Thank you so much.